Hi, my name is Sam Smith, and today I'm presenting my honors senior thesis on the effectiveness of insecticide-treated nets in preventing malaria in sub-Saharan Africa. Malaria is a mosquito-borne illness, and it presents with flu-like symptoms. It also can lead to possible complications, including fatalities. In 2016, the CDC estimated that there was 216 million cases worldwide, which led to 445,000 deaths. Malaria is especially prevalent in sub-Saharan Africa in children. Common public health interventions include the use of insecticide-treated nets, indoor residual spraying, and anti-malarial drugs. Insecticide-treated nets are bed nets that people sleep under. They're either pre-treated with long-lasting insecticides or retreated every 6 months. Mosquitoes searching for a host land on the net and receive a lethal dose of insecticides. Indoor residual spraying includes spraying of walls of households with insecticides about once per year. In a similar fashion as ITNs, IRS provide mosquitoes with a lethal dose of insecticide. There have been many studies evaluating the effectiveness of indoor residual spraying versus insecticide-treated nets. However, there is some variation among smaller studies. In Ghana, for example, indoor residual spraying was more effective in preventing malaria than insecticide-treated nets. In Malawi, insecticide-treated nets reduce malaria morbidity, as well as the use of long-lasting insecticide nets in the Democratic Republic of the Congo. In Rwanda, a study supported that they both lowered mortality related with malaria. When evaluating public health interventions, it's important to consider whether or not there are spillover effects. Spillover effects are whenever an intervention is used in the community and it affects people that are not using that intervention in the community. For example, a study done in Western Kenya evaluated the spillover effects of ITN use in a community that did not use insecticide-treated nets that lived nearby a community that did. And this showed that there were indirect protective effects for people that were not using insecticide-treated nets but lived near people that did. In this study, we will focus on long-lasting insecticide-treated nets. These nets don't have to be retreated, and data is widely available from the DHS. So our research objectives were to identify confounding variables that could bias effect estimates, estimate the direct effectiveness of ITN use on malaria prevention, determine whether spillover effects of ITN use among neighbors also conferred protection against malaria, determine if direct and indirect effects change over time, and determine if there is a total effect of ITN use versus non-use across neighborhood coverage levels. So we use a cross-sectional study method, and our causal estimates included neighborhood level average probability of malaria infection and overall average probability of malaria infection, as well as direct and indirect and total effects. So the way that we measured the neighborhood level average probability of malaria was the probability of malaria for users or non-users in a specific neighborhood based on the proportion of neighbors using an ITN. Similarly, the overall average probability of malaria infection was the probability of malaria infection for ITN users or non-users based on the proportion of neighbors using an ITN, but this was not just for one specific neighborhood, it was for the overall study. Direct effects included the difference in the probability of malaria for ITN users and non-users in a given neighborhood coverage level. The indirect effects were the difference in the probability of malaria for individual ITN non-users in neighborhoods that have differing neighborhood coverage proportions. Our data was obtained from the Demographic Health Survey Malaria Indicator Survey data, which is publicly available. Inclusion criteria included countries that were located in Sub-Saharan Africa, at least 2 surveys per country between 2007 and 2019. Each country had to have a baseline malaria prevalence of 25% at least, and we only use data for children under the age of 5. Here's a map of the countries that we chose based on the inclusion criteria. We had data from Liberia 2011 and 2016, Malawi 2012, 2014, and 2017, Nigeria 2010 and 2015, and Uganda 2009 and 2014. Here are variable descriptions, and these are the variables that we particularly looked at in order to decide whether or not we had confounding variables that needed to be controlled for malaria outcomes. This slide also describes how we decides whether or not someone was an ITN user, and this was based on data that we had available through the DHS survey, and that was whether or not the subject used ITN the night before the survey. The malaria result was based on the diagnosis of malaria based on blood smear or a rapid diagnostic test. Other variables that we looked at were mother's education, urbanity, whether or not indoor residual spraying was used, wealth, age, whether or not there was standing water nearby, and the age of the bed net. So we found confounding variables using chi-squared tests and two-sample t-tests. Based on our chi-squared test comparing malaria incidence versus selected categorical variables, indoor residual spraying, mother's education, wealth, and standing water were all chosen as confounding variables. Using a two-sample t-test, age of the child was also a confounding variable. We decided whether or not that the variable was confounding using alpha level 0.05 for significance. And then we chose bednet age as a confounding variable based on a previous study. Results. This first graph shows the distribution of the proportion of malaria cases per country and year versus the proportion of ITN users. So you can see that there is variation between each country. Overall, we had 32,332 children under 5 in our study, and this ranged from 2009 to 2017. The overall malaria prevalence was 42.7% for children under the age of 5. The prevalence of malaria did decrease in all countries across time. For all countries and years combined, 45.1% of children under 5 slept under an ITN the night before the survey. The percent of children that slept under a bednet increased over time with exception to Malawi. The second graph shows a distribution of people in each neighborhood coverage level. So we had 3 designated neighborhood coverage levels, 0 to 25%. So that means 0 to 25% of the population slept under a bednet the night before the survey, 25 to 50, and 50 to 100. And the reason that we chose to do 50 to 100 instead of breaking it up into 4 categories is just because of the amount of people we had in each group. So in the 75 to 100, it was so small that it skewed our numbers, so we grouped it to 50 to 100. So you can see that this also varied across country, and kind of like the individual ITN usage, the proportion of people living in a neighborhood with coverage of 50 to 100% increased over time with exception to Malawi. So this figure shows the direct, indirect, and total protection of all neighborhood coverage combined. Well, it's broken down into 0 to 20, so you can see it at each neighborhood coverage level. So first I want to talk about the direct effects. For all countries and years combined, individuals who lived in a neighborhood coverage between 0 to 25% and 25 to 50% and were considered ITN users had a reduced risk of malaria compared to ITN non-users. So at the 0 to 25% neighborhood coverage level, this was 2.9 cases per 100 children, and it was also 2.9 cases per 100 children at the 25 to 50%. It was insignificant at the 50 to 100%, meaning that there was no reduced risk of malaria. The total effects, so this was for ITN users living in the top neighborhood coverage, so that 50 to 100%, compared to ITN non-users living in the lowest neighborhood coverage. So the ITN users living in the top neighborhood coverage had 8.1 less malaria cases per 100 children as compared to the non-users living in a low neighborhood coverage. This graph shows the probability of malaria based on ITN coverage for both ITN users and non-users, and at each neighborhood level, they're actually not significantly different from each other, the probability of malaria. This is the odds of malaria for ITN users compared to ITN non-users. So this is the overall direct effects. Overall, the odds of malaria was lower for ITN users versus non-users for all neighborhood coverage levels combined. It is important to note that country and year-specific data varied widely. The only country with significant direct protection at all neighborhood coverage levels is Uganda 2009. Overall, for all countries and years combined, there was no reduction in malaria cases for ITN non-users living in neighborhood coverage between 25 to 50% compared to those living in a neighborhood with 0 to 25%. However, individuals that did not use an ITN and lived in a neighborhood with coverage of 50 to 100% had a reduction in 6.1 cases per 100 people. So this meant that there was indirect protection at the 50 to 100% neighborhood coverage level. In summary, the following variables were identified as confounders of ITN use and malaria status across most countries. Indoor residual spraying, maternal education, wealth, urbanity, standing water, child's age of the bednet. And these were all adjusted for in our indirect, direct, and total effects estimates. So around 32,000 children were included in this study. Malaria prevalence decreased in all countries across time. There was direct protection at the 0 to 25% and 25 to 50% neighborhood coverage levels, but not 50 to 100. There was indirect protection for non-users at the 50 to 100% neighborhood coverage level. So this indicates that there is an overall positive spillover effect in high neighborhood coverage. And this could also explain why there's not a direct protect at the 50 to 100% level, because there's an indirect effect, so they kind of overlap. The probability of malaria was actually not different between users and non-users across all neighborhood coverage levels. So overall, for people who lived in the top neighborhood coverage and used an insecticide tree net versus people who lived in the lowest coverage and did not use one, there was a reduction in 8.1 cases per 100 children for people that living in that top neighborhood coverage using an ITN. It is really important to note that results varied across each specific country and year, and some specific countries and years actually had a negative total effect. This was actually kind of a limitation of this study because we could not evaluate how country-specific policies and education were assessed using the DHS data, and these may be confounding variables as well. Mosquito ecology could also vary among different regions and countries. And finally, ITN users were classified by whether or not they used the bednet the night before the study, which could be inconsistent with whether they normally use an ITN. In the future, it would be important to consider different limitations such as differences in mosquito ecology and country-specific policies, and also to consider if changes in the climate and rainfall affect malaria prevalence. Here are my references. Thank you to Meredith College Undergraduate Research Program and the Shepherd K. Hausch Academic Enrichment Fund for undergraduate research. And a big thank you to Dr. Perez-Hadrich for advising me and the countless hours you have put into helping me develop this research. Thanks.